Could one of you please explain the difference between Parkinson's disease and Parkinsonian symptoms? What does that really mean when someone has those different diagnoses?
Hello? Oh, there we go. Well, so symptoms are what you feel and what, say, like a runny nose. You can have a runny nose and you can have many causes of runny nose. It could be allergies, it could be an infection, could have a foreign object up there. That's a symptom called a runny nose. Parkinson's symptoms are things like tremors, rest tremor, stiffness, slowness, walking, what many of you know, many causes of the Parkinson's symptoms. So that's called Parkinsonism. Parkinson's disease is one of the most common causes of Parkinsonism. So Parkinsonism is a description of the symptoms, and Parkinson's disease is a specific cause.
I'll just kind of add to that. A lot of folks will come in and they'll say, I've been told that I have Parkinsonism. Is that the same thing as Parkinson's disease? And it's not. And that's really where it's critical that a neurologist familiar with, or who's a movement disorder person, really separates out those things that look like Parkinson's, but we don't call idiopathic Parkinson's disease. There are some clinical characteristics that may vary. There's a handful of relatively uncommon syndromes, things like progressive supranuclear palsy, multiple systems atrophy, other things, normal pressure hydrocephalus, which is treatable with a shunt. So, and not to mention things like medication side effects. There's a whole list of medications that can make a person look like they've got Parkinson's disease, but they're Parkinsonian in appearance because of a medication side effect. So it's critical that that be sorted out, and I think that most movement disorder folks should be able to do that within the first hour to some extent. I mean, at least have a handle on it. It may require some further testing, scans, and so forth, but that's kind of a critical thing. Is it Parkinson's disease or is it Parkinsonism? They're quite different.
Okay, which actually also leads to the next question in regards to some of the diagnostic tools that we use to diagnose Parkinson's. So are there any blood tests? We talked about biomarkers. Going forward in the future, are there ways to measure levodopa and will testing be common in terms of future testing for like we're tested for cholesterol and we're tested for diabetes, and what are your thoughts about future biomarkers and testing and maybe skin testing and things like that in terms of diagnosis?
We were just having this conversation a little bit before. So as of today, still, it's a clinical diagnosis, and we have tools that may help us figure out whether it's Parkinson's disease or a different cause of Parkinsonism. So there's one test called a DAT scan. So that's a scan that looks at how much dopamine is in a certain part of your brain, how much is working. So somebody who has Parkinsonism, from those nerves that aren't working well, it's going to be a positive DAT scan, but it's not going to separate the different causes of Parkinsonisms except for one or two. So then there's a skin test, which many have heard of, called SYN1. That tells you whether you have abnormal alpha-synuclein. Now, abnormal alpha-synuclein is present in Parkinson's disease, but it's also present in some other disorders like MSA, multiple system atrophy. So it doesn't distinguish between that. There are blood tests that are not yet on the market, but they're being researched. But one of the problems is, one of the things we were talking about is, how did they determine whether that DAT scan was positive? They asked a movement disorder specialist, a group of them, what they thought. And that's the gold standard. So the reality is that a good movement disorder doc is as good as any of these tests. And then the question is, the most important question is, what do you do with that information? Why do you want that test? And we have a lot of different styles and different doctors and different patients. I tend to be very pragmatic and say, look, whatever the SYN1 is positive or negative, I'm going to treat your symptoms, and it's not going to change what we do. Now, when we have new therapies that are directed towards, say, alpha-synuclein, like the antibodies, then it's imperative to know that. So I think some of these tests are going to be very important when it comes to treatments in the future, but right now they're a help in distinguishing some things, but usually don't modify treatments. It's important to say biomarkers mean a lot of things. So biomarkers can be diagnosis, it can be how fast it progresses. There are many things, whether you're engaging targets. There's a whole bunch of meanings of biomarkers. And then finally, there's a whole bunch of questions in that. I don't think you need to measure levodopa or ever will need to measure it. It's how much gets in the brain is the most important and how best it affects you. So we dose it based on your response. I have some people, a half a centimet is too much, and another person takes 3 and it's not enough. So very individual, not based on blood levels.
Okay. And there were other questions regarding cognitive deficits associated with Parkinson's and the distinction between Lewy body dementia, Alzheimer's dementia, and Parkinson's. Is there an overlap, and how do you describe that to this population?
One of the movement disorder dogs.
I can keep talking forever, so do you want to take it?
Yeah, I'll jump in there a little bit, but I'm certainly want to defer to Dr. Bronstein on the particulars, other than Lewy body, diffuse Lewy body disease, cortical Lewy body disease. This term is oftentimes misused in my experience. The way that I look at diffuse Lewy body disease is when we talk about classic textbook, regular old idiopathic Parkinson's disease, the Lewy bodies are restricted to the substantia nigra in the upper brainstem. Diffuse Lewy body disease means you've got Lewy bodies scattered really up and down the neuraxis. And these are folks who present usually within the first year of their Parkinson's symptom, their motor symptom, within the first year, or sometimes even preceding the development of the physical, visible motor symptoms, they develop cognitive and behavioral changes, personality changes, for example. Sometimes we talk about frontal lobe behaviors like disinhibition or extreme apathy, just staring, off into space. Within the first year is kind of, I think, where that. But I think that, we try to put things into a box and we make these distinctions when, in reality, I don't know that it's actually nature's way, but that's how I look at it.
Yeah, I mean, there's clinical diagnosis and there's pathological diagnosis. So clinically, it's exactly right. You have Parkinsonism and cognitive impairment within the first year of the Parkinsonism. In 2 years, then it doesn't count as clinical disease. But that's really what we care about is what's underneath, like what's going on in the brain. And so it's pretty arbitrary, that distinction. But if you have the clinical syndrome that was just described, there's a pretty good chance that there's evidence of Parkinson's disease, the Lewy bodies in the cortex, but also some Alzheimer's changes. So there really is a spectrum where Lewy body disease really has a mixture of Alzheimer's and Parkinson's disease. It's kind of both. And it's really interesting now that we have a lot of genetics, the genetic risk factors for Lewy body disease are overlap of risk factors for Parkinson's disease and Alzheimer's disease. So this is where a lot of the semantics that drive me absolutely insane. There's clinical diagnosis and there's pathological diagnosis. So clinical diagnosis is exactly like that. Classical and pathological diagnosis has certain features. So if you just distinguish that, then we get rid of all this semantic stuff.
Okay, great. I'm going to throw some questions to Dr. Mischley as well.
I haven't been this quiet in a long time.
Okay, we had a lot of questions about exercise and high intensity exercise versus low intensity, the benefits of doing yoga, Tai Chi, meditation, those types of forms of exercise versus running a marathon and higher intensity type of biking and higher intensity exercises. Could you maybe touch on the exercise component to disease progression?
Yeah, so in short, more is probably better, and I think most of us would agree the best form of exercise is the one that you will do. There's no question that physically intense is part of it. There is a SPARK study happening right now, and it's pretty amazing to hear the number of people who have been assigned to the moderate level of exercise say, holy smokes, moderate is not moderate. Moderate is way more than I've been doing. And so I think a lot of you don't realize that you are not pushing it nearly as much as you need to be pushing it. There are a lot of studies that say the best possible thing you could do to improve your balance in Parkinson's is Tai Chi. You know, you're not breaking a sweat, but it still counts, it's still good. And so the type of exercise that you might need, you know, runner's high is dopamine. I mean, you're going to get some different physiologic effects from breaking a sweat, getting your heart rate up, going that extra mile than what you get from Tai Chi, but they both do something a little bit different. Very briefly, there's this sixth sense called interoception. And so people with Parkinson's have a little bit of a diminished sense of interoceptive sensitivity. So what that means is your body's ability to know yourself. So if a non-Parkinson's person can feel their heartbeat going up a little faster than a Parkinson's person can, I can feel my bladder when it's 65% full. A person with Parkinson's might not feel it until it's 95% full. And so it's not a bladder problem, it's a perception problem. And so things like Tai Chi and yoga aren't just exercise, but what they're doing is they're training your ability to better hear the signals coming from your body. So do it all, mix it up. I have 4 rules for my patients. Physically intense, cognitively challenging, outside your comfort zone, and so difficult you're getting frustrated and making mistakes.
I want to add to that because I think it's fantastic advice and completely agree with it. And I also just want to add that just doing an hour of intense exercise, if you sit on your ass the rest of the time, you're not doing yourself any favors. It's all the movement. So you don't have to, you know, I hate these people that drive to the gym, have to park right up in their disabled parking spot, and then get on the treadmill. Isn't that ridiculous? If you walk to the gym, you get just as much. Take the stairs. Don't park next or do that. I'm a big fan, my patients will, I'm a big fan of things like the Apple Watch and stuff that have the rings. You know, that red ring is just as important as that green ring, you know. Move all the time. And we see a spectrum of people. You know, some people, you know, I have 92-year-olds that are skiing, and every single one of those people that do well for decades are all the high activity people. It is, without a doubt, one of the most obvious things you see as a physician. It's what keeps me exercising. I get that perspective. I've learned from that.
I'm going to play the devil's advocate here a little bit. Which, as a general rule of thumb, the more the merrier. The more you can do, you can push yourself and so forth. But you know what, folks? Just getting out and walking every day, I don't hesitate to show my patients that I spent $9.99 on this little gadget, little pedometer, and I count my steps. And we liked, the gold standard is 10,000. But if you can get anything over 3,000, you're actually doing yourself some good. So it doesn't have to be super intense to get something out of it, it's great if you can, if you can go that route, but you know what, for just your average folks out there, walk, get those arms swinging, think big steps, think big and loud, right? So big steps, big arm swings, you'll be doing yourself a lot of good, and walk to a rhythm. Whether it's left, right, 1, 2, if you're musically inclined, walk to, having a cadence, having a rhythm really helps everything.
All right, and the exact opposite of exercise would be sleep. We know about the importance of sleep. And people want to know if you can get too much sleep, and what is an adequate amount of sleep, and what does that look like? Can you get too much? What is too little?
Well, there's a lot of not sure. So let's tell you what we know. Okay, so from a biological standpoint, we know, so I talked about those aggregates, right? Those aggregates are in Alzheimer's or different proteins in different places, but they're all bad. We know that when you sleep, you clear those aggregates out of your brain twice as fast than if you're not sleeping. And we also know that if you're drug-induced sleep with trazodone or one of the medicine, it doesn't matter, it still helps. So there's a biological reason that you want to get enough sleep. Now, how much is enough? You know, everybody will say 7 to 9 hours is kind of the standard. That's probably the best we know. Too much sleep, I think, is more of an indication that people are having certain cognitive problems. And so, you know, I don't know if it's bad for you or not. I know it's usually associated with people that are having problems, but not always. But I'm not sure of any data, good or bad, other than you're missing a good part of the day if you sleep too much. Often you want to make sure you're not sleeping too much because you're depressed. You want to make sure, you know, that you're getting good night. You don't have sleep apnea at night, things like that. So you need to figure out why. But if you take care of all those things, I'm not sure 9 hours or 10 hours is necessarily better or worse than 7 or 8.
And medication side effects can make you sleepy. That's another thing we want to watch out for. And if you haven't already, there's a fabulous book by Matthew Walker called Why We Sleep. It's on Audible, and you can read it. And if anyone wanted some motivation to save their brain and go to bed early, that would be it.
Okay, we have a ton of questions about diet and food. And we heard that about dairy, and there were a number of questions about yogurt. And what do we do if we don't eat yogurt? What do we do for our gut biome and improving our gut biome?
Eat fiber, fruits, vegetables. So first of all, this whole idea that the bacteria that are in yogurt are somehow necessary and essential to help you is not, we don't know. I mean, it is true. If you have a course of antibiotics and you take a little probiotic supplement, we can reset and help the microbiome. In Parkinson's disease, we know you have a messed up microbiome, but first of all, several studies have shown that you have way too much lactobacillus. It's not a deficiency, so you might not be messed up in the same direction that other people are messed up after a course of antibiotics and things like that. And as we were just talking about, a lot of what we're seeing in the different microbiome really is a function of the rate at which stuff moves through your intestinal tract. When a slow-moving intestine will grow different bugs than a quick-moving intestine. And so I don't think fermented cow breast milk is the answer to your healthy gut problem.
Yeah, I mean, we don't know a lot about the microbiome, but it's being studied extensively now. We both have studies going on, so we're trying to learn the importance. I did a study on myself, I have to admit. So so everybody taught me when we started doing this, you know, it's prebiotics. It's your food that you eat and not probiotics. So I had my microbiome tested in a good lab online. And then I ate so many probiotics you wanted to throw up. I mean, I just ate tons and billions and billions and billions, and I checked it again, exactly the same. It's what you feed those bacteria, and it makes sense. So eating the diet changes your microbiome, and maybe that's a good thing. Probably, we know eating the food is. If the microbiome may be the reason that it's healthy, we're trying to figure that out. But don't worry about the bacteria you eat, worry more about what you're feeding the bacteria that are in your gut.
And someone wanted clarification on fried foods. Do you imply fried foods being fried in oil or sautéed in oil, or what's the definition of a quote-unquote fried food?
If all of you would join the study, we'd be able to differentiate sautéing from frying, from deep frying, air frying. A study just came out that actually did look at the darker the product is in your air fryer, the more carcinogens it has in it. So even air fryers may be, it's a temperature thing. It's a temperature thing. So we don't know.
Just a quick shout out to one of our local neurologists, Dr. Erin Prasant. Dr. Prasant specializes in the culinary aspects of managing Parkinson's disease. Is she still here? Erin? No? Okay.
All right. And also, people are worried about their chocolate intake. Dark, light, milk.
I count that as nuts and seeds.
It's one of the major food groups. Dark chocolate.
All right, so we've talked about exercise and sleep and diet, and we also, thanks for touching on other determinants like loneliness and social isolation. Can someone speak to how depression and anxiety play into symptom management? And there are many medicines that are used to treat depression and anxiety that can interfere with Parkinson's medications.
Well, I touched a little bit about this on my talk, is that people are at very high risk for anxiety and depression. There's a biochemistry about it. Getting the disease diagnosis manifests with that, with anxiety and depression. And it makes what happens, you get lazier, you eat more ice cream, so it's really bad. You feel bad, it's really bad for your lifestyle, you do all the bad things for your health. So it's really important to treat it. So you can treat it many ways, and I think all of us would agree that exercising, being more social, doing natural ways of doing things, getting out in the sun is really important to help treat it. Some people, I think honestly most people with Parkinson's can use a little bit of lift of serotonin with some of the medications. But it's really, really important, the quality of life. You know, we're not trying just to live a long time, we're trying to live better and happier, and I just can't tell you how important it is to address that, maybe more important than the tremors and the stiffness. So it's important to address it, recognize it, and treat it.
And I'll add that treating the tremor and stiffness, they're not necessarily two different treatments. We have been surveying people every 6 months, and what we did is we looked at people's symptom severity in the 6 months prior to them starting levodopa and their symptoms in the 6 months after starting levodopa. And the two symptoms that improved the most were anxiety and apathy.
Yeah, so you probably know Jay Nutt. Mm-hmm. So Jay is wonderful neurologist up in Portland. He's retired now, but he did these amazing studies where he'd actually do intravenous infusions of levodopa in Parkinson's without the patients knowing. It was blinded. And he did all the finger tapping and stuff like that. And, you know, of course, it was related to the blood levels. But it was amazing how close correlation with anxiety and depression went with the blood levels of levodopa. It was striking. I have a slide, it's from the 70s or 80s that I always like to show when I teach the residents and fellows. It's so important. So a lot of people, they'll start getting anxious at the end of their dose, get shortness of breath. Really, really common, even before they get stiff. We see this a lot of people with surgery. Their motor symptoms are treated well, and they look great, but they feel like crap because their levodopa level's low, they feel anxious and depressed. So there's all kinds of aspects to it that need to be addressed, but recognizing it, I think, is really important.
In terms of new research and new frontiers with research, someone asked about GLP-1s that are so popular for diabetes and weight loss. Are there any studies going on with the GLP-1?
Yeah, so there were a couple good studies done, small studies done in the UK with exenatide that looked quite promising. They just released a very large, incredibly well done study on GLP-1s. It was just published a couple months ago, and unfortunately it was negative. So there was hope that there was this anti-inflammatory effect from it. So right now it doesn't look like it's too promising as a disease-modifying therapy.
Any other new horizons in research that would be of interest to this crowd?
I'm pretty excited about the NAD study that's happening, I believe, in Finland right now. It's called the NOPARK study. So Dr. Bronstein talked about mitochondria being the energy producers of the cell. And I work in the radiology department at University of Washington, and we can actually measure how much ATP your muscles are making. We can put you in an MRI machine and use spectroscopy to tell you. And we just published a paper showing that people with Parkinson's make about 15% less ATP than non-Parkinson's patients. And part of that has to do with a diminished, it's called NAD. And so they did a study a couple years ago showing that there's an over-the-counter supplement that you can take that very easily, within a month, raises your NAD levels in your brain and your body and decreases inflammation. And so that was so successful that they're now doing a study looking to see, can we slow Parkinson's progression using that, it's called NR, but it increases the body's level of NAD. So I'm personally pretty excited about that one.
So I'm excited to this concept of precision medicine or personalized medicine. So what we mean by this is something that's been really exploited well in cancer field. So many years ago, you know, if you had lung cancer, you're all treated with the same group of medicines, and some people got better or it helped, some people it didn't. So then they started genetically looking at the cancer, and they found, 20% have mutations that are the same ones that are treated better by one we use for kidney cancer. So if you gave that medicine to all the lung cancer patients, it would be a negative study because only a small percentage. So if you can identify that cause in that person, then so many of the treatments have failed, like the antioxidants have failed. But maybe if that 20% who have a mitochondrial problem, you treated them, it would help. So that's what I'm excited about, is knowing more about what causes Parkinson's in individuals and then personalizing that therapy. Now, there's the other side that says, well, we have some common features to it. So there's lots with synuclein, which I explained. There's a whole group in this gene and protein called LRRK2, which maybe it's a common genetic form, but turns out to probably be very important for everybody with Parkinson's, similar to synuclein, so directed towards those. So I think you plant all these seeds, and most of them are going to fail, but some of them may work, and some may work in a subset of people and not in another. But I do want to make one statement before, make sure it's over. So one of the things I've learned about, so I've been driving out to the Central Valley for 25 years, evaluating people out there. And one of the things that I've noticed is people in the Central Valley as a group did poorer than the people at UCLA. And it was striking to me. It was striking when I see some of these studies from Australia many years ago, how poorly people did. And I said, that's just not what we do. And what we've learned is that your general health is the name of the game. You take care of yourself, you keep your weight down, you don't have diabetes, you keep your blood pressure, you exercise and eat, and go to your doctor and get your annual physical and take care of yourself. That's going to affect your Parkinson's disease as much as anything that we do. So take care of yourself, and all these diets are good for your heart, it's good for your strokes, it's good for all that stuff. So just be healthy, and that really makes a big difference. You're less depressed. It just makes, it's the name of the game. And all these other things are just nibbling around the edges. That's the central, is just good health.
Not to be Debbie Downer here, but I can remember as a young neurologist when I first started practicing 35 years ago, I would frequently tell my patients, you know, we're going to have this thing licked in 15 years. And in fact, some of you may be familiar with the MPTP scenario. Well, I was a resident taking care of Bill Langston's patients at that time. These were drug addicts in the San Jose area. And Bill Langston's neurologist came across these folks that were actually in the psych ward, and they were diagnosed as having catatonic schizophrenia, meaning they were, well, he went in and said, they're not catatonic schizophrenics, they're severely Parkinsonian. And he got a sample of their stuff, had it analyzed, and found this toxin called MPTP, which really revolutionized research at the time. And I remember very clearly that we had high hopes that if we could use this as a tool, we can discover ways to block the progression of the disease. And a lot of, you know, very seminal and foundational research came out of that, but it didn't come to fruition. We had a lot of hope that high doses of the antioxidants that Dr. Bronstein, you know, at one time we were using mega doses of vitamin E. Well, you know, it turns out that anything more than 400 units a day increases your risk of heart attack and stroke. You know what? You can't just take these things indiscriminately. But so vitamin E didn't pan out. Then it was CoQ10, coenzyme Q10. That was going to be the thing. Antioxidant. Guess what? Didn't work. And then on and on and on. So I've had to kind of readjust my perspective in that, you know, it's incremental. We're getting there. We're moving in the right direction. But as far as if somebody asked me, do you see a breakthrough treatment, you know, within the foreseeable future? And my eyes are wide open, but I don't know.
I'll just add one more spin, is now that I have this app and it's available globally, I think we have over 5,000 people from 150 different countries. We, in this room, are already setting the curve. When you look, I mean, you can just eyeball the data and see how severe people are in Africa, in India, in Thailand. We are getting much, much, much better results here than what a lot of the world is experiencing. And so other people are looking to us. I mean, when I started giving these talks 10, 15 years ago, the room was not this well controlled. People were much, much more symptomatic. Like, you are living the next generation of Parkinson's.
And if you're an adult with Parkinson's, what advice would you give to your children in regards to Parkinson's? And is there any education? We know that there is a genetic component. What would you, or how would you counsel or educate your children?
Well, I'll start. So we'll start with the genetic component. So, like I said, a small percentage of the genes that, a small percentage of Parkinson's is primarily genetic. And even if you have one of those genes, so the most common is this gene called LRRK2, or it's called autosomal dominant. You have one bad copy. But depending, even if you have a bad copy, somewhere between 25 and 75% of people with a bad copy will never get the disease. So if you have the disease and your kid then has a 50-50 chance of getting, and you have a 5% chance of having that gene, or a gene, your kid has half that chance, and then they have somewhere between 25 and 75%, that means that there's over a 90% chance they're not going to get it. So that's number one. So I don't think the genetics should worry people too much. Now, there are individual families that are a little bit different. But in general, most people shouldn't worry about the genetics. And then you tell them exactly what we talked about. How do you prevent Parkinson's? I just showed you the best way to prevent it is you eat well, you exercise, you try to stay in a clean environment. That includes trying to avoid, riding your bike behind a truck, breathing those air, or living in highly polluted areas. Try to eat organic if you can, not especially it's called the dirty dozen, and learn about that. Avoid it. Again, don't be so neurotic that you're going to drive yourself crazy, but it's not binary we talked about. It's you do the best you can and enjoy your life. That's my advice. I don't know.
Oh, I guilt trip my kids a little more than that. We have a list of the food points on our table, and about once a week, everyone has to add up their points, and whoever has the most bad points has to do dishes for the week. And so our rule at the house is we don't bring that stuff on the bad list into the house. We don't want it as part of the day-to-day lifestyle. I want my kids making informed decisions, and they're going to make whatever decisions they want when they're out and about. I just want them to know the difference and be aware that the choices they are making will have consequences that they will not feel for years to come. And it's fun to watch them get older and older, and now I can hear them talking about, oh, do you see, all my friends who eat X, Y, and Z, they get sleepy after lunch, they have bad acne, they have, they're old enough that they can start to see how some of the foods affect behavior themselves. But I think, and then on the online Parkinson school that I have, I made, there's a class that's a free class for the family members of the of patients. And it's me being the nag about the dairy and the fried food. I mean, it's different when it's mom and dad telling you. But in that video, I kind of go through a list of early symptoms. It's everything I want your kids to know. If you get constipated and you're acting out your dreams and you have, these are the things we want to be on the lookout for. Come talk to us if you have it. And then here are the exercise and dietary recommendations for you to implement today that will decrease your risk of being diagnosed later.
I think one of the most important messages that I try to deliver when I see a patient for the first time is it's so important to have the family involved. And so I like to see adult kids, and they come in and they usually before the discussion begins, they've got this downcast look, and people have the misconception that Parkinson's is inherited, and it's not usually. I mean, by and large. I mean, there's a certain percentage where it may be, but just telling the family, telling the adult children who have their own children, because mom or dad has it, listen, chances are that you are not going to, this is not an inherited disorder for most people. And that's kind of a burden lifted. I don't usually do genetic testing. We can if we want. And for individuals with what we call early onset, which is less than under the age of 50, you might consider, testing, but I don't usually do genetic testing.
All right, I think we'll conclude with this last question about palliative care. Could you please define palliative care and explain when this might come into play in the life of someone with Parkinson's?
You would probably be better at answering. Yeah.
I'm the moderator.
Well, maybe that's one we all address because I think it's an important point. And there's not a precise definition. It's trying to, this is going to be my interpretation of the definition. It's probably going to be wrong by the experts in the field. But it's really quality of life. It's accepting that there are going to be limitations, there are problems that come along, and how do you live well despite that? And that's how I see palliative care. So problems with mobility, how can we solve those problems with mobility? How can you be safe in the shower? How can you do all of these things to have a highest quality of life possible? Understanding that at this point, this is not a disease that we can cure. So we accept a certain part of limitations, like we all do as we get older, and try to live the highest quality of life possible. And it's separate from what we call hospice care, and that's really important. We're still treating people in palliative care, There's no expectation you have 6 months to live or less. This is just accepting some disability and improving your quality of life despite that.
That's exactly how I define palliative care too. I think of palliative care doctors as experts in quality of life. And this is a little depressing, what I'm about to say, but I would actually say that palliative care begins the day you're diagnosed. Frankly, the best tools in our toolbox, really all we have to offer you are things that improve your quality of life. We don't have anything to stop progression, to reverse this disease. Really, all any of us are doing in terms of symptom management is palliative care. And I am really excited to expand what we have to offer into some of these more offensive therapies, more disease-modifying strategies. But right now, I would argue you're already all getting pretty good palliative care medicine.
Yeah, I do want to add to that, because I think that's really important. There's a big change in medicine going on now, which is everything's getting fragmented, and it kind of drives me crazy because we have our palliative care experts, and I see residents and fellows and some of these people earlier in their careers say, okay, I'm going to send you to palliative care. That's what we should be doing. I should be doing that right from day one. I know my patients better than some impersonal person that's going to cookie cut and not know your lifestyle. Because every person's so different, and what means quality of life to them is different. And who better to know that than your doctor who's worked with you for years, and you get to develop a relationship. So as important as having palliative care experts be part of it, and I have partners with that are incredibly helpful and know more about some of these things than I do. It's so important for your primary neurologist and your primary care doctor to play an integral role in palliative care. I think it's so strong, and I don't want to just say, okay, well, my job's over, I gave you your Cinemet, you take it, okay, go to the palliative care, and they're going to help you with the rest. So that's my philosophy anyway.
All right. Well, thank you so much for your expertise. Your knowledge is just so great for all of us. And we just really appreciate you coming to Santa Barbara, and hope that you can come back and visit us again.
Thanks for having us. I really appreciate it.
Thank you very much.